Welcome to section 25 of the Falcon Physician Review series in the Anatomy Online segments. Now we're going to wrap up thorax by talking about the posterior mediastinal structures that we haven't discussed already and a little bit of diaphragm. When we look at the posterior mediastinum, one of the very important clinical things to understand is the venous drainage, because a lot of clinical conditions will affect the venous drainage, and we'll deal with some of those in the next segments of the abdomen as well. We have the superior vena cava above the heart, and we have the inferior vena cava below the heart. The superior vena cava, of course, drains everything from the limbs and the head in the upper portion, and the inferior vena cava drains everything below the diaphragm. It's the thoracic cavity itself that will use as a collateral supply and a connection between the IVC and the SVC, the azygous system. Notice also the thoracic duct that's running up on the midline component of the azygous system as well. The azygous system has a general game plan but has a lot of variations. The key features of this are the anastomoses that allow blood flow to travel from one system to the next if there should become blockage. We start out with the subcostal vessels of the thorax getting received blood from the ascending lumbar branches, which would be essentially the same as the intercostal branches but draining the abdomen. Then we have the azygous system on the right, because this is a right shunted system, that will drain the posterior intercostals directly into the azygous vein. The most superior intercostal spaces will be drained down through the superior intercostal vein, which can either go into the azygous system or sometimes into the arch of the azygous system. On the left side, however, there's going to be a hemiazygous system, which will collect the lower intercostal rib spaces and then cross over as the hemiazygous vein into the azygous vein. Above those, the middle to the higher ones are going to be drained by the accessory hemiazygous, and they'll cross over into the azygous vein. And then you have a couple branches of the superior intercostals which will drain directly to the brachiocephalic vein. This is an important shunting system because these connections to the body wall and to the vena cavas and to the organs within will allow bypasses should systemic or portal hypertension start to develop. Now, let's do a question. During thoracic surgery on a patient that had been injured in an auto accident, the surgeon gently elevated the esophagus off the vertebral bodies and searched in the mid-thoracic area between the azygous vein and the descending aorta for any injury to the structure located there. What was the structure she was likely checking for? And the answer here would be the thoracic duct. The thoracic duct can sometimes be injured in thoracic surgeries because it's a very thin-walled structure that ascends just posterior along the vertebral bodies, and it will ascend typically between the esophagus and the aorta, or sometimes the esophagus and the azygous venous system. Since it's so delicate, tearing of this during thoracic surgery can result in a chylothorax, which is often the reason that brings them back in looking for damage for it. Here we can see the right hemithorax dissection that I was working on that shows that you have the arch of the azygous system, and here you can see the thoracic duct, which would run right in this area here and can be easily damaged during surgery. There's the greater thoracic splanchnic nerves that are coming off the sympathetic chain that can be seen running down here with these triangular ganglia. This greater thoracic splanchnic will be heading towards the abdominal viscera. In the left hemithorax, now we can get a view of the hemiazygous vein as it will cross over after draining together some of the upper and lower venous intercostal spaces, as in the case here. There was not an accessory hemiazygous in this individual. What you can see also coming off the sympathetic chain are these rami communicans, which will be the sympathetic autonomics that are trying to get back onto the ventral rami to distribute to the body wall. The Pancoast tumor is something that you should think about in the clinical understanding of tumors, because this Pancoast tumor, indicated by the white arrow, is in the apical component of the superior mediastinum, but it's compressing on either superior or posterior structures as a result of its positioning. If it produces a Horner syndrome, it could be compressing the sympathetic chain, or it could be pressing on the roots of the brachial plexus, giving you brachial plexus signs and upper extremity symptoms. And that's seen here with the brachial plexus shown with the black arrows. Let's do another question. A patient has spasmodic contraction of the blood vessels in the upper limb, especially in the digits, resulting in pale, cold hands that are prone to ulceration and gangrene. The attending physician suspects poor circulation due to a hyperactive sympathetic system. The anesthesia, or the block of what ganglia and the nerves passing through it, would stop the sympathetic flow to the upper limb. And it's the stellate ganglia that's involved in the sympathetics that would go and supply the upper limb. That stellate ganglia is a connection of the inferior cervical ganglia and the T1 sympathetic chain ganglia. When those fuse together, they look a lot like a little starburst because there's little axons and whatnot coming out from all over the place. The ciliary ganglia is associated with the eye. The middle cervical ganglia is associated with some of the major vessels of the neck and the skin of the neck itself. And superior cervical is the last stop for sympathetics on the way to the head, and the dorsal root ganglia is a sensory ganglia that would not be involved in an autonomic response, because autonomic things are motor, and that's a sensory one. But what you can do surgically in this posterior mediastinum and superior mediastinum, in this case, position, is that they can ablate some of the autonomics that would be distributing to the upper limb, and you can deal with things like hyperhidrosis if there's an overactivity, or you can have Raynaud's disease, which would shut down the peripheral vessels, leading oftentimes to ischemia, cyanosis of the hands, and that general and uncomfortable cold feeling that these people experience. If we have an infant that's diagnosed to suffer from a congenital diaphragmatic hernia through a large defect in the posterior lateral part of the diaphragm, the defect in the diaphragm is due to failure of development of what structure? And this, of course, is C, the pleuroperitoneal folds. Now there's 4 different things that connect to the diaphragm to form it. Pleuroperitoneal folds are a very small component in the adult form of the diaphragm, but play a very large role during the developmental process. So if the herniation occurs because of a failure of these pleuroperitoneal folds in the embryonic stages, it actually allows the viscera to herniate up through and into the thorax. And this will have some clinically relevant deleterious effects to the developing embryo. Let's look at the diaphragm first. The diaphragm has a couple portions to it, the peripheral and the central components. The central components are tendinous, which makes sense because you have your IVC passing through there and you don't want muscular components to compress that. And then you have the peripheral components, which will have muscle that's grown in later on from the intercostal areas. That will be sternal, costal, and lumbar muscular components. There's really 3 things that we need you to know that pierce through the diaphragm and the levels that they go through, and this will be important for imaging when we'll see a little bit later. The inferior vena cava tends to go through at T8 in the relaxed position. The esophagus will go through at T10 vertebral level, and the aorta will pass actually behind the diaphragm at the level of T12, which also makes sense because if it goes behind the diaphragm, when the crus of the diaphragm contracts down, it will not compress that major vessel. And this is just showing a few of those demarcated structures and where they're going through. Look at the development of the diaphragm so that we understand how we get to this adult formation. 4 things are contributing to the development of the diaphragm. That's septum transversum, which is coming from the forehead region and folding under. Around the edges of the pericardioperitoneal canal, which is a result of the folding, there is some pleuropericardial fold. This pleuroperitoneal fold will close off. If it doesn't, then there's going to be a deficit remaining from that canal. And in the embryo, the pleuroperitoneal membrane needs to fuse to the esophagus and the septum transversum, and around the esophagus there's some mesentery that will contribute to the crus of the diaphragm. So in the embryo there's a very large portion of this pleuroperitoneal membrane that's important in the diaphragm being closed. Later on, though, this will regress as the muscular components start to ingress and form more from the body wall. Here's another question. The following plain film was acquired just prior to surgery in a neonate that was prenatally diagnosed with the condition seen, congenital diaphragmatic hernia. What's the biggest risk to the infant's life if surgery were not immediately performed? And the answer to this is B. There could be respiratory distress or respiratory failure, because what happens with this infant is that when the bowel eventrates up into the thorax, you have hypoplasia of the lungs since there's no room for them to develop. Also, they end up with a lot of GI problems, but this would not lead to death like the problems with the malformed lungs would. So with this congenital diaphragmatic hernia, you see that the pleuroperitoneal canals fail to close because of the membrane. This is going to result in pulmonary hypoplasia, and this can lead to pulmonary hypertension, and that is indeed fatal. Many of these are called Bochladiec hernias, where the posterior lateral malformations are the ones that result, and they tend to be on the left side. Eventration is a little bit different in that the diaphragm forms, but it's very thin and balloon-like, so it allows the abdominal contents to penetrate up into the cavity without actually getting to the cavity. There's still a thin membranous separation between the two, but the effects are going to be very similar. This concludes our discussion of the thorax.